inspiration. This is my two inspirations. What is going to happen is that there is going to be a change because पहला 2-3 बीट का जो inspiration हो गया उसका मुझे this is the variation I'm getting in the arterial pressure. Okay, this is the variation I'm getting. Now this pressure from here to here, which is the which is the high, this is the high, maybe this is the highest pressure, maybe high, this is the highest pressure, is PP max, pulse pressure max. This is pulse pressure max. The low pressure here is called PP minimum. It's called PP minimum. Correct? Now PP max minus PP minimum divided by PP mean, that is max plus minimum divided by 2, mean into 100 is called as pulse pressure variation. This is called as pulse pressure variation. This is called as pulse pressure variation. You don't need to really do this calculation because in our monitors PPV can be easily seen. You just put PPV, it will start seeing. It gives you that. Clear on this? So PP max minus PP minimum divided by PP mean is the formula. But on our monitors, if you have an arterial line, you will get PPV there. And it is important that any time that you have your arterial line on, the PPV level should be there on your monitor. It is very important. Clear? Clear? SN want to give everybody. So clear on this? Am I clear till now?
Yes.
Am I clear till now? Now there is a number defined on this. The number says if your PPV is more than 13%, this means this patient is fluid responsive. This means this patient is fluid responsive, which means to say if I give the fluid, the cardiac output will increase by 10%. Am I clear till now? What does this mean? That if I have an arterial line, it's a crime if I don't have PPV. I need that PPV there. You understand? Because without that, I can't give a single drop of fluid. Are you getting the point? Clear on this? However, this PPV works only in certain conditions. It cannot work in any patient that is there in the intensive care unit. It can work only in certain conditions. And what is that condition? A, the patient should not have any spontaneous breaths at all. He cannot have spontaneous breaths. That means if he is triggering the ventilator, we can't use PPV. With this number, with this 13% number, we can't use it. Samajh mein aa raha hai? So a patient has to be absolutely no trigger. Patient should not be breathing on their own. Okay, so mechanically ventilated with no spontaneous breaths. This is the first. Logically, can you tell me where else it will not work? With now that you know what is dynamic indicators, dynamic is because of the heart and all these things coming together. Logically, where do you think it's not going to work? Spontaneous हो गया ना? Spontaneous it's not going to work in spontaneous. Then arrhythmia, rhythm disturbance. Because if there is rhythm disturbance, obviously the atrioventricular we are hoping that whatever venous rhythm is reducing, na? But if the heart itself is not okay, where so rhythm disturbance, it's not going to work. It's not going to work. Then
Low lung compliance.
correct, low lung compliance. Why?
That squeezing thing and everything
Will not occur only because if the compliance is low, the pressures are not transmitted only. The pressure that we have to the alveoli, the pressure that transmits the alveoli will not occur only. At high pressure will not get transmitted. So low lung compliance. That's why you must know the button on your ventilator where C is there. Compliance. Okay. So if the compliance is less than 30, it will not work. If the compliance is less than 30, there is no point of looking at pulse pressure variation. The compliance has to be more than 30. You can give it S1. Clear? Clear? Then what?
low section.
No. So the other thing is you need to create this, no? And to create this, there has to be good tidal volume. So you can't have it less than 8 ml per kilogram tidal volume. If it is less than 8, for example, the ARD is giving 6 ml a kilogram tidal volume. You can't use this PPV. We can't use this. It has to be 8 ml per kilogram tidal volume to actually use this one. And the other thing where it can't use is when there is too much of tachycardia. ठीक है? So if there's two other tachycardia, it's called shock index, heart rate divided by systolic blood pressure more than 3.6. Heart rate divided by RR is more than 3.6. If it's more than 3.6, heart rate divided by RR is more than 3.6. That means this is the situation usually in ARDS. In a patient with ARDS, you give a high RR. If that is the situation, you cannot use this kind of parameter. Clear on this? So you can't use it with extreme tachycardia. You can't use it with extremely low respiratory rates. You cannot use it with low compliances. You can't use it with low tidal volume ventilation, and you can't use it with spontaneous breathing. Clear? So whenever you are using PP, pulse pressure variation, you have to be clear whether I am doing using the number rightly. You can't use the number when it cannot be when it is not right. Because when it is not right, you must also remember what the Frank-Starling curve says. What is the Frank-Starling curve? You have preload here, and you have cardiac output here. Frank-Starling curve. This is how your curve looks. You just showed that curve. Okay. So in that curve, what is happening is, if you increase preload, that is increase volume, and these areas, even if you increase small amount of volume, the cardiac output increase is very high. But if the person is somewhere here, and you increase the same amount of cardiac, same amount of volume, the same amount of volume if I increase here, the cardiac output is negligible. The cardiac output is literally negligible. Cardiac output. Correct. So our entire point is to figure out with this, all these things, is to know whether the patient is here. You understand? With this fluid responsive, all these things we are talking about, we are only trying to figure out where is the patient. Is the patient here or is the patient somewhere here? Because if the patient is here and I give the fluid, there is another curve called as EVLWI curve, which is somewhere here, which is superimposed on the Frank-Starling curve. Extravascular lung water index curve. Okay, what is going to happen in this extravascular? Here, there is no increase at all of extravascular lung water, where it reaches here, right? But here, it is very steep. It's the other way around over here. Here, if you give the fluid, the preload, it is very, very steep. So, the extravascular lung water, it's ulta of this curve. You understand? So, the extravascular lung water index will go high if you are in this region. That means the lung, it will leak into the lung. You are getting the point? It will leak into the lungs. You getting the point? So, the other curve that is there is called as a Phillips-Merrick curve. This is the Frank-Starling curve. This is a Phillips-Merrick curve. इसमें क्या हो जाता है? If by any chance you are in this part of your curve, your extravascular lung water will go high. Correct? That's why I cannot do any fluid challenge without doing some assessment of fluid responsiveness. Clear? So let's put a very simple patient that comes to you. Patient was inside the casualty. Patient was very bad, and they intubated this patient with cardiac. They intubated this patient, put an arterial and sent the patient to you. You have given 30 ml per kilogram. Now that mean arterial pressure is 55. You find 55 is not that okay. The urine output is just coming in. There is no good about urine output. Now I want to decide whether to give fluid. Now this patient is otherwise intubated not because he has ARDS, just intubated because acid already. He will be intubated what on top. He is otherwise sinus tachycardia. You have given a good tidal volume of 8 ml per kilogram. And with that you are finding PPV to more than 13. Clear indications that let me give the fluid. Correct? Because it has fit every parameter that I wanted over here. It has fit every parameter that I wanted. So in that case it's very simple. Look at the PPV. It is higher. This patient's MAP is low, urine output is not okay, he's still mottled, his capillary refill time is not okay. Indicator saying this patient may be requiring some fluid. If I require and my PPV is more than 13, I need to give the fluid. I can't just look at PPV more than 15 and give the fluid also unless the patient requires it. So if the patient's MAP is 60-65, urine output is coming, capillary refill is good enough, but the PPV is 16, that doesn't mean give the fluid. You're getting the point? There has to be three parts, I told you. The first part is he requires. The second part is responsive. And the third part is effect. So the first part is does he require? So if the person is not having any of these parameters that we talked about, if we talk, is not there, there is no requirement. So even if the ppv max is more than 13, ppv is more than 13, there is no point of giving any fluid. Are you getting the point? समझ में आ रहा है? Clear? But our patients are not like this, no? Our patients will have spontaneous breaths. Our patients will have a heart rate that is very fast. Our patients' compliance will be definitely, many of them will be less than 30. Many of them will be rhythm disturbances. You know, and most of our patients will be at less than 6 ml per kilogram. More than less than 8 ml per kilogram. So most of our patients will not be able to use this PPV max. Correct? Correct. So just like this PPV max, there is also PPV, there is also SVV, stroke volume variation. So if your monitor gives you stroke volume, flow track gives you stroke volume, we just discussed cardiac output monitor. So stroke volume it gives you. If that is giving you SVV, that also says if it is more than 10%, if it's more than 10% here, stroke volume more than variation more than 10%, that is fluid responsive. Clear? But this also follows these parameters. Correct? Now the situation is what? Most of my patients are not like this. Then what do I do? Question is now what do I do? Most of my patients are definitely not like this. So what do I do further? So what is the thinking? So there are other parameters, other dynamic fluid responsive parameters that we look at. Okay. Given this scenario, so when all these things occurred and we were able to find PPV max and PPV minimum, all those things, still that thinking, अरे यार जब ये spontaneous breathing होगा तो क्या करने का? Which are the other parameters we have? So at this stage, they also looked at the IVC because it's the easiest thing to do, ना? तुम्हारे पास ultrasound है, IVC लगा के देख लो. Correct? So what they started looking, just like how we discussed on IVC, they looked at the IVC diameter, and looked at IVC diameter variation. IVC diameter variation. That means maximum diameter, IVC maximum minus IVC minimum divided by IVC mean. Diameter. This is about diameter. So IVC you can do for diameter. Okay, look at IVC diameter. So what did they do? They again kept a probe on the M mode. They looked at the maximum diameter, looked at the minimum diameter. Then IVC diameter maximum minus IVC diameter minimum divided by IVC diameter mean into 100. If that was more than 18%, if that was more than 18%, it was said to be that the patient is fluid responsive. This again did not work very well when it was spontaneous, though it was better than CVP. It was better than CVP. The area under the curve was somewhere around 0.75. Not 0.8 and 0.9. 70% of the times you may be right. If you do something like this. IVC diameter. Okay. Then they did what? They did IVC distensibility, collapsibility index. What is the IVC collapsibility index? So they looked at IVC, same thing, IVC maximum minus IVC minimum. I want IVC maximum. They just converted the mean to IVC maximum. And if this was more than 40%, it was called fluid responsive. Okay, and then when the patient was on the ventilator, since collapsibility doesn't work, collapsibility when the patient is not on the ventilator, it is not going to collapse as much. Correct? It's going to distend when the ventilator is reducing. So it's they came up with IVC distensibility index, where IVC max ki jagah pe they put IVC minimum. So very simple thing, IVC max minus IVC minimum divided by IVC mean is IVC diameter variation. IVC max minus IVC minimum divided by IVC max is collapsibility index. And IVC max minus IVC minimum divided by IVC minimum is IVC distensibility index. IVC distensibility index, which is 18%, around 20%. Clear? Clear this? Clear? So here the area under the curve is somewhere around 0.7, 0.75, 0.76. So in a spontaneously breathing individual, if I do on a mechanical ventilator, the IVC distensibility index seems to be the best marker to be used among all of these. IVC distensibility index. That means this more than 20%, is 75% of the times I would be right for fluid responsiveness. If I do IVC distensibility index. Clear on this? Any doubts on this? So I'm not just going to look at the IVC and say he's hypovolemic or hypervolemic or fluid responsive. If I have to figure out whether the patient is fluid responsive, I will look at the IVC, I will put it into the equation over here, and then figure out my IVC distensibility index in a person who is being mechanically ventilated. Clear on this? Am I clear? So now I have got two parameters in my mind. My first parameter is PPV. I know SVV, but we are not using the SVV, so I'm not talking about SVV. PPV. If parameters are not getting spontaneous, the patient is spontaneously breathing, which we keep our patient spontaneously breathing, I have the ability to do IVC diameter 75% of the times. Clear? 75% of the times I can do this. Clear on this? But what if there is other things over here? Rhythm disturbance and all the nonsense that is happening over here. Is spontaneity, I understand. But what about rhythm disturbance? What do I do? There's something else I need to do. And that is why the test that comes to our mind in such cases is, any idea? So what have we covered till now? We have covered PPV, we have covered SVV, we have covered IVC in the dynamic parameters. And on IVC we talked about diameter variation, we talked about collapsibility index and distensibility index. Right? These are over. Then if my patient has all of these problems, what do I do? Okay, that is our main patients. These are our main patients. So the best test to be done in these cases is called as PLR, passive leg raise. Now anybody can tell me what a passive leg raise is? Can you tell me passive leg raise?
When we when we ask the patient to passively raise the leg, there is an increase in the cardiac output of 300 ml.
Okay.
And if there is an increase in cardiac output due to the passive leg raise, that means patient is fluid responsive.
But that means by how much?
10%.
Now if you think about it, what is the definition of fluid challenge?
Increase in cardiac output.
4 ml
4 ml per kg.
Crystalloid.
Crystalloid. Fluid responsiveness means give a crystalloid.
10%.
The cardiac output is equal by 10%. And if this occurs immediately, it means that there is fluid responsiveness. We are exactly using this over here, but there's a technique. When you're giving fluid responsiveness, we don't tell the patient anything. We give the fluid. So here we cannot ask the patient. First of all, the patient has to be absolutely calm. Patient cannot be in hyper state. If the patient ऐसे करके breathe कर रहा है, then his sympathetics are working hard. His sympathetics will prevent venous return. His sympathetics will prevent the venous return. So he has to be calm and quiet. And you will start the patient, you will have to have what? A cardiac output monitor. You have to have a high fidelity cardiac output monitor that will give you in seconds. It will change the numbers in seconds, in minutes, So you need a cardiac output monitor. So my requirement here is cardiac output monitor. I need a cardiac output monitor. Clear on this? Without a cardiac output monitor, I can't do a PLR test as of now. Clear? And that also it should be a good cardiac output monitor, not the one like a pulmonary artery swan. In a swan, what happens? I have to do thermodilation, then I'll get cardiac output monitor. I need a continuous cardiac output monitor, a CCO, a continuous cardiac output monitor. You understanding? Something like a PICO, something like a continuous cardiac output from PAC line, from the swan gans line. I need a continuous cardiac output monitor. Clear on this? So I need a continuous cardiac output monitor here. I need the patient to be in the propped up position. Patient should be in the propped up position. 45 degrees propped up. He has to be at this position. Patient, he or she has to be in the 45 degrees propped up position. And then what do? And then when the cardiac output has come, we first, if we have a PICO monitor in our ICU, which we have, we will first do the thermodilation and figure out what is the cardiac output. Now we have the cardiac output there. अभी इसको cardiac output बता दिया उधर ऐसा cardiac output है. Now what we do? After doing this, we tilt the bed. We don't move the patient. We don't ask the patient to do anything. We tilt the bed such that the patient becomes like this. This is step 1. This is step 2. This is step 2. The legs are going up. The patient remains supine. What happens because of that? The thoracic blood volume as well as the leg blood volume now causes an auto transfusion or an auto fluid transfusion into the heart. An auto transfusion to the heart. Clear on this? Huh? All the fluid that is there in the legs and in the lower part of the abdomen now rushes into the heart. Clear? When it rushes into the heart, what you are expecting, like it's like a fluid challenge. What you are expecting, cardiac output has to increase by 10%. So in the next 1 or 2 minutes, I should see the cardiac output increasing by 10%. Correct? The cardiac output has to improve by 10%. If that occurs, and then third step is getting this patient back to this position, and the cardiac output goes back to what it was earlier. This is a definite test to say that patient is fluid responsive. Clear on this? This can be done in spontaneously breathing individuals. It can be done in mechanically ventilated patients. It can be done in mechanically ventilated patients who are spontaneously breathing. It can be done in any group of patients who's arrhythmia, who's having compliance problem, who's having any kind of issues, heart rate being fast. It can be everything. It can be used. So the PLR is a test of choice when it comes to giving fluids in any patient. First of all, clear. So I'll repeat that once more. Patient has to be in the proper position. There are 2-3 prerequisites of this. Patient cannot be having intra-abdominal pressure. If the patient has got an abdominal catastrophe, obviously it's not going to work, no? Because the fluids are going to be sequestered there. Okay, so in an abdominal catastrophe, like for example, you have a gut perforation, you can't use the PLR because fluid is sequestered there. Clear? So, and if there is data that says that the spine is bad, you can't really put the patient on proper position. You can't use it in those spine trauma patients. You can't use. Obviously, you can't use this particular test because the patient needs to be initially in propped up position. Okay. So propped up position. Look at find the thermodynamics, find the cardiac output. Then move the patient to the position that we have in position number 2 here. With the legs up. Wait for a minute or two. Watch what happens to the stroke, what happens to the CCO. If the cardiac output increases by 10%, that means if it's 4.1, it has become 4.6. That means it is a 10% increase. Okay? If the 10% increase, that is अगर 2.5 है, तो 3 अगर हो गया, 2.8, 2.9 हो गया, cardiac output. Or stroke volume, it was 60, it has gone to 10%, 70. If it goes to say, if it has gone to 70, this means to say that the patient is fluid responsive. Clear on this? So, you have PLR, you have IVC versus stroke volume, PVC. Now you understood PLR? PLR you understood? Now what happens? Everybody does not have a cardiac output monitor. I mean, in this hospital, in the whole Bombay, maybe 2 of us have cardiac output monitors. One may be HN hospital, one may be us. You understand? Pico nobody is using only. Okay, so cardiac output monitors also are less. All they have is that APCO monitor and that all these. These are the usual cardiac output monitors. So what do you do in these cases? The other thing you can do is echo. In the echo, it's important to do something called as aortic flow velocity. Very difficult to do. It's not easy. बोलने के लिए आसान है. You have the heart. This is how the echo looks. When you do the heart, 4-chamber view. You have the aorta here. You have the aorta here, and you have a flow that is coming from here. You put the Doppler here. Put the Doppler here. Put the pulse wave Doppler there. That means you first find the 4-chamber view. You have the aorta. You find the aorta. Color डालेगा तो तुमको aorta मिलेगा तो यहाँ पर ऐसा aorta दिखेगा देखो. On that you put the pulse wave Doppler. You will get an image that looks like this. You get an image that looks like this. This over here there will be VTI. You just take VTI. It will give you the VTI there. The value here. Then you do this PLR with the hand like that only. Move it because it's continuous now. Move the patient to this position. Wait for some time and repeat doing this echo. And you find whether the VTI, which is basically a stroke volume, increasing by 10%. That's why doing the echo becomes very, very essential. Doing the echo becomes very, very essential because you can actually do this. But of course, it is operator dependent. Every one of you, maybe one person may be able to do it. It's operator dependent, it requires experience and it requires effort, a lot of effort to do in this case. Okay? So this is called as flow velocity or velocity time integral, VTI, velocity time integral across the aortic valve. So VTI across the aortic valve, velocity time integral across the aortic valve will actually tell you fluid responsiveness. Clear? So PLR coupled with cardiac output, PLR coupled with velocity time integral. Clear? These are the two things you can do when you do PLR. Correct. Are there any other tests? There are many more tests that have come in now because there was so. This has been proven 0.9% accuracy, 0.95% accuracy PLR. So it's beyond doubt that this is something that you can use. What else you can use? If you phone in there, so you call upon. Clear? So this is PLR cardiac VTI. Okay. Now the fifth one. What do we do in these cases? You already have the PPV, right? You already have the PPV here. You already have the PPV here. Pulse pressure is already there. In most of these patients, you have an arterial, you have a PPV already. There is no harm if you have a PPV here. Correct? Now, what can I use the PPV further? That's the question that comes into my mind. If the patient is mechanically ventilated. So there is something called as tidal volume challenge test. What do we do in that? So your patient was at say 6 ml per kilogram. Let's take 50 kilo individual. He was at 300 ml. He was at 300 ml. This was a standard volume. This patient's standard volume was 300 ml. Okay. And my PPV showing 8, for example. PPV showing 8. And the patient is spontaneously breathing. And the patient has rhythm disturbance. And the patient has all this nonsense that is happening. What do I do in this case? Very simply, I will increase this 6 ml to 8 ml per kilogram. So if he is 50 kilos, 5 8s are 400 ml. And I will see what is happening to my PPV. If my PPV goes up by 3.5, if it goes up by 3.5, okay, 8 say वो 12 हो गया. What does this indicate? This indicates fluid responsiveness. Simple test. Simple, very simple test. Okay, tidal volume challenge. And everyone sitting in this room should know this test by heart because this came from India, from Mumbai, from Tata Memorial. It has been proven all over the world now. So it came from Tata Memorial. Dr. Devetia and Sheila Maitra, they came up with this view. And you should know this test, okay, because it's an Indian test. Okay, so 6 ml per kilogram, say you increase to 8 ml per kilogram with the PPV on the background. If it goes from 8 to 12, you are 95% right in giving that fluid challenge. Simple?
How much should it increase?
By 3.5.
Absolute number.
Now, absolute number. It's a percentage only, na? PPV max is a percentage only. So 8% to it may be 3.5%. That means it go up to say 12. You understand? So if the PPV max is going up very clearly by 3.5%, okay, this means to say that this patient is fluid responsive. Clear? Clear? This very simple test to do. Very, very simple test to do. This is called as tidal volume challenge. This is called as tidal volume. Just like we give fluid challenge, this is tidal volume challenge. So momentarily you are increasing from 6 ml per kilogram to 8 ml per kilogram, affecting the change in the venous resistance and thus causing this particular PPV max to change. Clear? So very simple test to be done bedside. The other test you can do. So now I have explained to you what is tidal volume challenge. The other thing is end expiratory occlusion testing. Now, when you want to find intrinsic peak, you press a button called as end expiratory occlusion. You press that button called as end expiratory occlusion. Inspiratory occlusion will give you plateau pressure. Inspiratory occlusion will give you plateau pressure. So if I hold at inspiration, this is my inspiration. If I hold at inspiration, it will give me plateau. If I hold at expiration, this is my flow waveform. If I hold at expiration, it will give my intrinsic peak. So end expiratory occlusion. When I press the button on the ventilator called as end expiratory occlusion, and I have my cardiac output monitor. Okay, I need to have a cardiac output for this. I press end expiratory occlusion for 15 seconds, just for 15 seconds, and my cardiac output increases by 5%, by just 5%. It means to say my patient is fluid responsive. Simple test. So just press end expiratory occlusion, 15 seconds you wait, look at the cardiac output. If the cardiac output increases by 5%, I will immediately put the patient on, give the patient a fluid in the event that the patient requires the fluid.
Sir, all these parameters should be there.
No,
EE or
no, everything can be negative. So these are tests beyond PLR. These are tests that can be used without any of these parameters being accepted. So these are the tests that you actually need to know. The PLR, the tidal volume challenge, and the end expiratory occlusion test. There is more. There is plethysmographic variation index and all those things, but we will not go into that. But these are the things that you are using otherwise. There is Doppler guided. There is ultrasound Doppler guided. So all these things are there, but let's not go into all these things. So now let's go back to our patient. Okay, now I'm going to give you a patient, and now you tell me how you want to manage. Okay, we have a patient who came to the casualty. The patient had a fever of 39.8 degrees, 102 degrees fever. Patient is complaining of burning micturition. And the patient is breathing at a respirator of 26. You do a blood gas, the bicarbonates are 10. Okay, blood gas bicarbonates are 10, and the blood pressure was around 90 systolic. So the ER has given 1.5 liters of fluid, and because he was kind of tachypneic and acidotic, he was mechanically ventilated. This patient has come into the ICU, and in the ICU you find the BP to be 90, urine output is barely there. Barely there. What do you do next? Now that you know all of these things, what do you do next?
Clinical history. If patient is CKD, or we should know that.
History.
Basically, history we should be.
History to ho gaya. History is done. This is the patient. Now,
Ejection
now,
fraction, or if the patient has a low ejection fraction, we need to.
where is in fluid challenge and all these things? Where is ejection fraction coming? It's not really that big a problem for us. This is a clear patient.
In fever, febrile patient, we can clearly give fluid.
How can you give fluid? He's received 1.5 liters already here. He has received the initial 1.5 liters. This doesn't mean that the patient is fluid responsive.
So then, what about his weight? So it's 1.5.
You have 1.5 liters. I'm telling you 50 kilos.
Okay.
Abhi kya karna hai next? So this what you said is actually completely wrong. You get the point? This is not how. This is exactly how you must not think. You understand? You get the point? How what Kunal said is exactly what you must not think, which you normally think. Okay, you should not think like that.
Patient.
If a person has come in from the casualty, received 1.5 liter, this is the usual patient. Our patient comes like this. Our patient comes like this. What is the next step?
You should know the fluid responsiveness by
First, you must figure out whether the patient
fluid responsive.
Needs.
requires. The first thing is whether the patient requires the fluid. It doesn't come into responsive at all. You have to first understand the patient requires. So if you come here and figure out, okay, you will now touch the patient. What you should have asked me, sir, what is the capillary refill time? What is the fresh blood gas? How is the urine output? What is happening? Is the urine dark? Is the patient still breathing heavily? These are all indicators saying maybe this patient may require fluid. It's a maybe. It's not 100%. It's a maybe. We got only two things we can do: either give fluid or give vasopressor. There are only two things we can do. Correct? You have given vasopressor. Blood pressure is 65. MAP is 65. That doesn't mean patient does not require the fluid. You just bought the MAP to 65. The patient may still require the fluid. There might be other parameters. The hand is not okay. The capillary refill time is not okay. There is some mottling that you are seeing here and there. Some blanching rash is there. So you might say, "Arey yaar, isko urine output barabar nahi aa raha hai." I think I need to. I think this patient may require fluid. Now, once the thinking in your mind comes that the patient may require the fluid, that is when I'm thinking, that because whatever fluid has gone inside is now going to exude out. 3 hours में वो जो fluid बाहर निकलना वो निकलने वाला है. तुम्हारा next fluid भी निकलने वाला है. लेकिन and in the interim, I don't want to have organ hypoperfusion, right? I don't want that organ hypoperfusion to occur. My entire plan is to prevent that organ hypoperfusion in that interim, because by that, after some hours, my antibiotic is going to work. My vasodilatation is going to go. My glycolysis is going to get better. But in the interim, I want to perfuse my existing organs. It is in that interim that I'm using fluid responsiveness. Are you getting the point?
Yes.
You're getting the point I'm saying. So in that interim, what do we do now? Now tell me what I do. Now you want to shoot Kunal. What do you do now?
Now we check first for the requirement.
Yeah, so there is a requirement. Now we have all these things in place.
For responsiveness.
Correct.
Check for
What do you do now?
Heart line.
Correct.
Check heart
You
line.
put an arterial line. So there is no doubt you put an arterial line. You put an arterial line. Immediately put an arterial line. So you put an arterial line, and on the arterial line, what do you want to see?
Yes,
See,
PPV.
In arterial line, I want to see PPV. If I have an arterial line, I need to see the pulse pressure variation. Clear? Now, as you did this, there is an arrhythmia that developed, and you started giving him. And when you saw saturation was not coming up, you put him on ARDS ventilation. So you put him on 300 ml of tidal volume. Hmm? Okay, now when you're doing this, let's give the example of the patient's PPV came as 18. PPV came as 18. Before all this happened, the PPV was 18. Let's put it this way. Now you did the PPV and the PPV was 18. Now,
Patient is fluid responses.
mostly there is a good percentage that this patient is fluid responsive. I'll give the fluid. I'll give my fluid challenge here. Okay? But this parameter remains the same. The parameter remains the same, and now what has happened is after the fluid challenge, the bicarbonate remain the same, the patient is still not okay, capital refill is not okay, urine output has not come. You have given your 500 ml of fluid. Okay? It's not okay, and now your PPV is also showing 18. But now what has also occurred is patient has developed a rhythm disturbance. And you find that the oxygenation is not okay, and you put the patient on 300 ml of tidal volume. Now what is the next step?
Challenge test.
Sorry?
IVC. IVC.
Correct, you can do anything. You can do three things here. Now, what are the three things you do?
Tidal volume challenge
I
test.
can do a tidal volume challenge here, right? I can do a tidal volume challenge where I will increase this from 300 to 600 or 300 to 500, 8 ml per kilogram. I'll go up on that. I'll see whether fluid responsiveness is there. If I don't have tidal volume challenge, if I don't know how to do tidal challenge, or before this, even before arterial line, I can actually do IVC here. So the options are there, but this is a less, not as good an option like this. Because the area of the curve is somewhere around 75, but it's around 98. So preference would be PPV. Okay, so this is, and then you do tidal volume challenge or
IVC collector.
Or?
Distance.
Passive level.
for PLR what do I require?
Echo.
No,
Echo or cardiac output. So I can actually do cardiac output and do PLR to get this, or
Distance.
in these cases there is one definition that says where I can still use PPV with PLR more than 15%. PPV with PLR I can use more than 15%. There is one criteria that says, but why would I use all this when I have the tidal volume challenge? It's very simple to do, correct? Or I could do cardiac output with either PLR or with end expiratory occlusion testing. Clear on this?
Yes.
Now this is a patient who came in like this, and you have intubated. Now, what if this patient was not intubated?
Passive level.
Now what do I do?
Either IVC or passive level. No, sorry, passive level.
So either IVC, where I'm doing what?
Collapse.
Collapsibility index, with more than 40%. Very poor test, extremely poor test, extremely operator dependent, and we are not certain whether they're doing the right thing. It is going to be right only 70% of the times. But what is the best test?
PLR.
PLR. I'll do a PLR. And how do I do a PLR? Either by using cardiac output monitor or by using echo. And then decide on the fluid. Okay, I did all these things. PPV was not responsive. What is the next step? Vasopressors only. Increase whatever vasopressors are wrong, increase the vasopressors. Nothing else you can do. You have to increase the vasopressors. Clear?
Sir, the parameters you said, do they include or exclude vasopressors? For
It includes everything. This is how it's going to be. It's going to be like this only all your life. There will be vasopressor on, there will be everything on. Mean arterial pressure is not equal to tissue perfusion. Mean arterial pressure is not equal to tissue perfusion. So today if your mean arterial pressure is 70, it is not equal to tissue perfusion. Tissue perfusion depends on clinical parameters and overall status of the patient. Altered mental status, mottling, lactate, capital refill time, how is he doing, how warm is he, how is he responsive, how is his RR. That is clinical. You get the point? So all your patient will be like that only. Your query to fluid giving, I want to give fluid or not giving, will be dependent on that. Just because a patient is responsive doesn't mean he needs the fluid. Just because a patient needs the fluid, I cannot give the fluid. You got the point? In order for me to give the fluid, the patient should be clinically requiring the fluid and should be responsive by any of the tests that I said. And the third part of the story is, after you do this, has the effect come back? Has the effect got better? So you can't complete here. You have to complete this in another 30 minutes. by looking at whether the capillary refill time has got better, whether the patient has got warmer, is the pulse getting better, is his ventilation getting better, is his RR getting better, is his tachycardia settling down. Not one parameter, multiple parameters together in which says that okay, this patient is doing well. Because whether you have a successful fluid challenge again is a question in 10% of cases. This test is not 100%. You get the point? And that's the reason you need to understand what is the definition of fluid challenge and what is the definition of fluid responsiveness and what is hypovolemia. Clear?